Thank you. I'm really delighted to be here, and I'm appreciative that I stand between you and lunch.
No. We're pure intellectuals. We eat. We just eat ideas, so have no fear.
So my cognitive reframe in psychological parlance is that at least I'm not having to speak to you during lunch. So with that in mind, you'll have to bear with me. I'm going to try to truncate my presentation a little bit because I know we're really running over. And feel free to either talk with me today during this meeting or correspond with me offline. I'm really happy to talk to anybody about this because it's a topic I feel really strongly about. Right now in America, 1 in 8 Americans are 65 years and older. And that number is going to dramatically increase. By 2030, it'll be 1 in 4, or 72 million Americans. So this is really an important issue. And so I'm really delighted to have this opportunity to come and talk to you about it today. I want to highlight the issue with disaster response by giving you a brief story about what recently happened in Tampa, where I'm from. Tampa, Florida is home to MacDill Air Force Base. And so as a result of that, there was a nursing home that was located really close in proximity to the Air Force Base. And a call came into the police department saying, "We just opened up a closet, and we found a pipe bomb in this closet." So the police showed up with the bomb squad. Not only did the police show up, but also MacDill Air Force Base showed up because they're concerned because it's really random to have a pipe bomb in a nursing home closet. And so they're thinking, well, maybe this is just one of maybe a series of attacks. And so rightfully so, they're very concerned, and they show up in full force. And you look out the window of this 2-story nursing home, and you can see all of these units surrounding the building. So they started to empty out the building, which if you've ever tried to move a whole bunch of older adults, happens very, very slowly. And as a result of that, about an hour and a half into it, they made the decision that they were going to have to try to disarm this bomb, and that the remaining people in the facility were going to have to stay there during that process. So the staff, God bless them, they told their residents that they were going to stay with them. They were not going to leave, and they actually decided to do that. And they made a call home to their loved ones as well as the residents saying that this might be the last time. This is what's going on. They were saying their goodbyes. Everybody, as you can imagine, was very fearful and emotions were very heightened. And about an hour and a half later, they determined that the pipe bomb was really made out of plastic. It was really authentic looking, but it had been used as a training device in another exercise, and a former employee had accidentally left it there before they quit their job, and there was nothing behind it. So what happened is that you had a group of people who really believed that their lives were over. They really believed that this was it. And you know who showed up to comfort them and take care of them the following day? Any guesses? No one. So if this had been an elementary school, if this had been a high school, if this had been a junior high school, we would have had droves of crisis counselors who would have shown up to comfort the teachers, to support the social worker or the school counselor trying to provide care to those students. They would have been people climbing out of the community trying to assist them in terms of dealing with that traumatic event. But because this was a nursing home and it was older adults, no one showed up. I showed up because the Florida Healthcare Association called me and said, this is what's going on. So I took time off from the university and went down and talked to staff and residents. But I think that this is really a marker of a much larger problem that we really need to address. To that end, I had a lot of network envy when I saw the National Child Traumatic Stress Network map go up earlier, and I saw the 70 sites that have been established. By no means do I think that funding shouldn't be going to that I have 4 kids, I think kids are extremely important, but I think that a similar type of network should be in place for older adults. One that's sustained, one that's visible, one that's for professionals, one that's for older adults and their families, and nothing like that exists. Briefly, we had the geriatric education centers funded for a 5-year period, where they did some terrific work in coming up with some great evidence-based practices. But guess what? When the funding dried up, so did they. And all their great materials they kind of disappeared. So we talk about dissemination and not reinventing wheels. Well, until we figure out a better way to have a sustained network for older adults, this is not going to take place. It's not going to be a visible network. So that, if I could wish and have my magic wand work, that would be my number one recommendation, is that we have that type of similar type of network for older adults as for children. And there's some advantages and some consequences, and I'm going to talk about the bad news first. Some of the consequences are that if we don't have it, and you look at disasters, and you look at the morbidity and mortality of who actually is dying, who actually is getting sick and having adverse consequences, it's older adults, consistently across disasters, even internationally across disasters. They tend to fare worse than younger populations. Valuable time also is spent post-disaster trying to fund entities. So we've got grant makers in aging, who's a wonderful organization, and we've also got government agencies that'll step in to try to fund short-term projects. And so you've got people who need to be taken care of and responded to in a time-sensitive fashion. And in reality, you've got these really great, talented folks trying to ramp up their new funded program, find staff to staff them, do outreach to folks. So they're basically spending 6 to 8 months messing around trying to get things up and going. So we've got this expansion and contraction of services that wouldn't happen if we had a sustained network. We also have the media right now, to point number 3, doing a really good job warning people about conmen. We've had a series of incidents in Florida where roofers and people who do repair work, they would come back out to the community and they would talk people out of their insurance money. And these people in turn would have nothing to show for it. So the media picked up on this and was doing a terrific job of really making it known that older adults in particular were prey to these folks and not to give up their money, to really hold steady. As a result of that, and because they're so inundated with people approaching them, trying to get them services, trying to get them help, a variety of people who are legitimate and not legitimate, many older adults who are in the community are failing to take action because they can't discern who's trustworthy and who's not. We need to have a clearly identified source, again, that's sustained over time, that's visible, that's known to people before a disaster occurs, so they know who to turn to. So I think that's a really important take-home point. I'm going to turn off my mic. Relief workers also and crisis counselors are not adequately trained to be able to work with older adults. I think they do a terrific job of getting them ready to deal with children and with families and healthy middle-aged adults, but not so much older adults. So you get somebody that comes in and shows a little bit of cognitive confusion, not quite sure what's going on. I'm not so sure that a trained crisis counselor is going to be readily able to identify that they need to do a mental state exam and make a determination if this person's able to take care of themselves safely in the aftermath of a disaster. And access to services is not clear. Again, some older people, and we'll talk about this in 2 seconds, aren't able to stand in line for long periods of time. Either they're caregivers to other people or physically they lack the ability to be able to do that for themselves. And so having one-stop shopping with a known person to them would make a huge, huge difference in terms of being able to provide good services. An important point to think about is that not all older adults are an at-risk population. We tend to lump them all together. Anybody 65 years and old is at risk. Well, my father's 91, and he would be actually part of the solution and not somebody needing services. He actually could go out and help neighbors and do something to make a difference. And so I think it's really important that we also understand that older adults, and I'm actually jumping ahead to my next slide, which I'm going to talk about right now, they have developmental issues just like children and teens do. So we wouldn't group together toddlers and teenagers. Clearly you can see the distinction. And with older adults, we also have a situation where the young old are different from the old are different from the oldest old. But that's not necessarily a good way to think about dividing up those groups, and I'll address that as well in a minute. I think that we need to think about how we can take healthy older adults, regardless of their age, and turn them into volunteers. Find ways to really tap into that resource, that there's things that they can do. They have a lifetime of experience. They may have some impairments, but they can be used to really augment existing systems of care and strengthen it. In that regard, we need to have JIT, or just-in-time programs, that are available. If we want them to do something and they don't know explicitly exactly what they're supposed to be doing and how they're supposed to be doing it, at least to have some print materials and some ways of conveying that information to them rapidly, in real time, boots on the ground, where they can actually make some meaningful outreaches to others that they might be able to assist. The other idea is using neighbor-to-neighbor approaches, and that's something that I've been keenly interested in my own research. So that's my own personal disclosure for the day, is using a peer-to-peer approach. Somebody that knows you in your neighborhood through neighborhood watch programs or through other initiatives can really, again, help to shore up existing systems of care. I already talked about this, the developmental differences, and I don't think that that's the best approach to take. I don't think we should clump all people, but I do think that there's an important clue, and that is that if you look at the constellation of risk factors, and that is, what is their health status? Are they a caregiver? Are they cognitively intact? Do they have impairments in terms of being able to see or move or hear? If you look at the constellation of factors and you look at where they're living, so a 73-year-old in a nursing home is going to look wildly different than a 73-year-old who's living in an independent living community, in a senior residence. Ironically enough, the person that's living in a nursing home actually might be better off than somebody who's aged in place. And that is because regulations are in place to make sure that that older adult gets on a bus, is evacuated in a timely fashion, is provided the care that's needed post-disaster to make sure that they're doing well. So I just wanted to, share a couple of my thoughts with you today. And again, I know that we're really pressed because of time, so I am happy to talk to anyone afterwards.
Thank you so much, all three of you. Let me just